Hello, everyone. Welcome. You've made it here to part one of our Sublocade series. So this is going to be an overview of Sublocade administration, what you need to know. While we wait for folks to trickle in, we do have some polling questions for you, and we're going to launch the first one here right now. So that should come up on your screen. So go ahead and answer that. Another 5 seconds. All right, closing, and about 90% of you are healthcare providers. Launching the next question here. Go ahead. Five more seconds. All right, and about 80% of folks are from an urban area in BC. Third question. Another 5 seconds. So for this one, it's about a 50-50 split between people who know the current coverage process. So this will be one of our key learning objectives today, so we'll make sure to cover it for you. Next question. Sorry, I think the numbers are missing there, so it's an odd question, but 1 being not at all and 5 being very comfortable. Another 5 seconds. So about 50% of you are not at all comfortable with administering Sublocade, and not surprising given it's so new, but we are hoping to cover a lot of this information for you today in this webinar. And our last question. Five more seconds. All right, and closing that poll with not a single vote for yes to have prescribing this option. So definitely recognize this is a new option, and we're glad you could join us in this webinar today. So we're gonna get started, and I'm gonna share my screen with you all. My name is Amanda Giesler, and I work at the BC Centre on Substance Use on our education team. So we're gonna dive into this today. Before we get started though, really wanted to take this time to acknowledge the lands in which we're all gathering and calling in for today. I'm doing this on behalf of my colleagues here in the Lower Mainland. And so we're working on the traditional territory of the Coast Salish peoples, including the unceded homelands of the Musqueam, Squamish, and Tsleil-Waututh First Nations. But it is really important to reflect always that this is a provincial webinar, and that wherever you're calling in from, to give your thanks and your gratitude for the lands in which you're calling in from today. We did want to send a special acknowledgement over to some folks that helped build this slide deck. So there have been people who have been doing educational efforts as well as helping to prepare educational materials when Sublocade was eventually listed. So a big thanks to Tamara and Anne, two pharmacists that put together a number of these slides for us today. So here's our agenda today. We have an hour and a half for this webinar. First and foremost, we're going to be going through all the details regarding administration of Sublocade. So you're going to get to see the delivery system, the storage, the coverage, getting patients on this medication, any reactions to be aware of, the pharmacokinetics. We're going to do a little bit of a dive into the research evidence, but noting that this is a three-part webinar, and we're going to really do a lot of the research and the discussion in part 3 of this series. And then we're going to look into some actual cases. So how it's been going at Foundry, and we're really lucky to have Layla, and I'll introduce her in just a moment, to review how it's been going and some administration tips, missed doses, through a case series that she's going to present with us today. And then as always, we have lots of time for questions and discussion. And if you haven't joined us on a webinar before, we're going to be taking questions through the chat function. So if you go ahead and look at your panel, you'll see you're able to submit your questions. Please go ahead and do that at any point in this webinar, but we will get to those at the end. And we are going to save at least 20 minutes to have those opportunities for questions and discussion, given how new this medication is. So with that, we have 3 incredible speakers here, and all have experience with this medication, and it is newer, but they do have quite a bit to offer to us today in terms of this educational webinar. So first is Dr. Paxton Bach, who's a MD. He's a clinical assistant professor with the Department of Medicine at UBC. He also leads our FLEX program at the BCCSU and is on the AMCT team at St. Paul's Hospital. We have Dr. Mona Kwong, who's a pharmacist. She owns her own pharmacy in downtown Vancouver and is the pharmacy advisor and director of the Addiction Pharmacy Fellowship at the BCCSU. And last but certainly not least, we have Layla Gold, who's a youth clinic nurse. And so she's going to be sharing with us her cases and tips to date, as they've had some folks in Foundry get started on this medication. And so she'll be walking us through all of those administration tips later today. So thanks for joining us, all 3 of you, and we'll get started here. So today, I think we have a clear sense of what we're going to cover, but we are noting that this talk is going to focus more on the administration, the coverage details, whereas in session 2, we're going to get into some nitty-gritty cases, some specialized settings that this is going to be used, and some trickier considerations. And then part 3 is going to be more the research, getting into the literature and having a discussion amongst colleagues. So you're definitely welcome to join us for all 3 of these webinars, but we're glad you're here with us today. With that, I'm going to pass it over to Mona Kwong, who's going to walk us through a little bit of the injection pieces and as well as storage and coverage. Go ahead, Mona.
Thanks. And note that this webinar is being recorded, so you can refer back to it. And we also have a bulletin that you can refer back to as well. So Sublocade is an extended formulation of buprenorphine, a monthly abdominal subcutaneous injection that Leela will go through in terms of how to provide some tips on it. Notice of compliance by Health Canada in November 2018 only. And as Paxton and Leela will say, that it has been available as special access in Canada, especially in BC, the last little while. FDA in the US approved it in 2017, and there was experience also even prior to that in Australia. In June 21st, 2019, basically the Canadian Drug Expert Committee since then recommended it to be covered for treatment of moderate to severe opioid use disorder in adults. So that's when some of the special access requests were put through. And it does include part of a complete treatment plan, including counseling and psychosocial support. Indications-wise, I did mention moderate to severe opioid use disorder, stabilized, person needs to be stabilized, anywhere from 8 to 24 milligrams of the sublingual buprenorphine prior to starting the sub-Q. The special authority form also states that there's the need to be on sublingual buprenorphine slash naltrexone in our case for at least 7 days prior to the first injection. Naloxone. Okay. Dosage-wise, when you look at it, it is a box. It's sterile, clear, viscous, colorless to almost like a yellow tinge solution in a single dose pre-filled syringe. So it will come in a box. There's 2 strengths available. Really important to really look at everything because there's 2 different types of boxes. There's 100 milligrams per 0.5 mil syringe and also a 300 milligram per 1.5 mil syringe. Single use pre-filled syringe. It's a 19 gauge 5/8 needle. The recommended dose, so that you are aware, it's a 300 milligrams subcutaneously for at least a month, at least 26 days apart for 2 doses, so 2 months in total. Then usually it's a step down to a 100 milligrams subcutaneously monthly maintenance dose. However, in a lot of cases, it can be increased to 300 milligrams subcutaneously each month if required, depending on if the patient experiences ongoing cravings or other illicit opioid use. So we have some individuals that have stayed on the 300 milligrams. This is a delivery system that's kind of neat from a delivery standpoint. It's called an Atrigel delivery system. So what it means is that when there's an injection of that solution into the subcutaneous space, there's a solid that really rapidly forms. So polymers, actually it's designed with polymers, will respond to that water within that subcu fat and precipitates out and traps the buprenorphine alone into a solid implant. So it becomes a depot in this case, a little bit of a bump around the abdominal area. It is a controlled release formulation, and it does release the buprenorphine over time because it's biodegradable, and basically the drug actually degrades, or the polymer degrades by hydrolysis and releases the buprenorphine slowly over time. Storage-wise, if you look at the upper right, I just kind of took a picture of a pen in general. So the box actually is probably around 1.5 of the length of a pen. It is a refrigerated product when it comes, stored at 2 to 8 degrees. Generally, it is stored prior to in the fridge prior to administration, but we can also go through a little bit more in terms of the different requirements that's required in British Columbia for this particular medication at this moment in time. When it's ready to give, the dose is removed and at room temperature for at least 15 minutes. And Leila will go through some of her procedures at Foundry on how they've actually implemented their workflow to incorporate the most comfortable injection as best as possible. So outside the fridge, what's really, really important is that it can be stored up to 7 days at room temperature, only from 15 to 30 degrees prior to administration. So this needs to be built in terms of workflow with the timing, and things need to be done to mark the boxes properly when things are out of the fridge. No longer than 7 days, otherwise the issue is the product is not great to use anymore. Coverage right now, it can be considered as another treatment option as discussed. When you look through the clinical judgment, you look through the patient, you go through different things to determine whether or not there would be a benefit from a once monthly formulation. There could be challenges with treatment retention, for example, and the cases will actually in session 2 will go through a little bit more about this, as well as the case study at the end of this talk. So prescribers interested in BC prescribing Sublocade, there is a general special authority request form that needs to be completed for each patient. So in your EMRs, you can use your general special authority request form. What needs to be included, if you go through a stepwise procedure, and you also look at our bulletin, this is a summary from our bulletin, but I'll highlight some of the information presented in the bulletin. It's really confirmation of the moderate to severe opioid use disorder. clinically stable on 8 to 24 milligrams of the buprenorphine naloxone for a minimum of 7 days. And the current dose has to be written down on this special authority form. And any additional clinical rationale, so put everything possible within that space. Information that does not to be included. You do not need to include a copy of the prescription. You do not need to include the pharmacy information at all on the special authority form. Depending on what's requested, PharmaCare might actually write back and request additional information depending on the situation to really look at the requests and to come up with a decision. Special requests and authority coverages forms can be faxed, standard number, or mailed, but most people do fax. It is a lot faster that way. The same as any other special request forms, they are prioritized by date received. SUBLOCADE is actually going to be classed as urgent. And once the request is processed, PharmaCare will notify the prescriber of the decision. So that means by fax, usually to your MOA, who looks at it and flags it accordingly to your EMR. Do wait before you write the prescription for those prescribers until after you've been notified of the approval, because that does make it a lot easier for flow and also for you to book your patients back into the clinic for injections. It's really good that the SUBLOCADE special authority requests, urgent requests, so usually processed within 1 to 2 business days when things are faxed in. If you don't hear back, do call them and so that they are aware that there is something waiting in the queue. Duration of coverage, there's a different step process. Coverage is valid from the date that approval is entered on the record on PharmaNet. As pharmacists, we don't see when the approval date is completed. So sometimes on your prescription as a prescriber, it's actually very helpful for the pharmacist to know when the special authority is covered up to, and then we can note it on our files within our community pharmacy setting. The duration of the initial approval will actually be up to a year, and renewal will be considered upon another written submission. So do flag it on your patient's profile in order to ensure that it does not run out when the patient is due for the next injection. And usually they do require like a 2-week if possible, but do flag it for your MOAs to pull that. So what's really important to know is that make sure your patients are still registered on a Plan G as well. This is covered under Plan G. Also covered under Plan C for patients that are on Plan C or Plan W. This is particularly important because there are medications that people pay for that are not part of Plan G, and if the individual is not part of Plan G, they will be required to pay for a medication, which does cause a bit of a delay in therapy. And this is also dependent on whether or not, for the social workers out there that are aware, and the finance workers, the individual needs to fill out their income tax. Otherwise, there could be consequences to the plans expiring out. So transitioning patients to SUBLOCADE is, people are hearing about it a little bit more. There's tons of questions from patients about it, tons of questions from prescribers as well as pharmacists and other healthcare providers about it. So everybody has a role to look at the benefits and risks of transitions for sure in the discussion prior to a patient going to a prescriber. And if there is a decision made to switch, definitely document the discussion, the decision, what's a clinical rationale, especially as noted within the special authority form. And then after everything has been confirmed through PharmaCare, this is the BC program, then the prescription for SUBLOCADE should be written using the current controlled prescription program prescription pad. And so that is that duplicate pad that you see, the blue one. Over the next period of time, you will note that this duplicate form will transition into a common form for the methadone as well as other 1A or narcotic drugs, Donexo-Lowell. You'll see that in the next few months or so by the end of the year, hopefully, for the new duplicate forms. A patient's pharmacy should then be contacted. That way, as a community pharmacy, we know that there is a plan to transition. We know how to obtain the product from the manufacturer, because this is a very different product from the usual supply chain that we see or that we order from. So it is a special process that I will outline in the next few slides. So ordering information for pharmacists that are out there in community setting, you must email. If you have not received any information about this product, you must email this email provided to obtain a direct opening account form. After the form is completed, then you have to email the completed form to that same email or even fax it in order to get the information to the ordering company. You, as a requesting pharmacist, will receive an email with your username and a separate email with your password within 1 to 2 business days. What's really important is that they actually require a work email. So you have to discuss it amongst your staff, amongst the pharmacy, how to proceed with this. And then both are required, so that you know the completed form and also the email with your username, both are required to access another platform, which is a controlled substances e-ordering form. It's a completely different platform, not your usual ordering system through McKesson, through Uniform, through KNF, through your special other wholesalers that might be linked to like a Shoppers or other locations. So really important to keep this in mind, because your prescribers might be prescribing these soon. So the other one is, after everything is done, is also a very different ordering system to reconciliate your narcotic inventory. To order the Sublocade, you actually have to download everything, complete, sign, and mail. You have to mail the original copy of the controlled substance e-ordering form to the address located there. Then afterwards, the company will validate your license. You will receive an email containing a private key. Then you have to complete the order that needs to be finalized. So this does need a bit of time. So the turnaround time needs to be taken into account when your prescriber writes a prescription for one of your mutual patients. So build in this time, and it might take a little bit of understanding and reflection before you actually get this process going, because it is quite new to many pharmacies. This is not something that you as pharmacists in the community often order from. There's another thing that, as in practice in community pharmacy settings and also with your prescribers, is there is a unique dispensing pathway. Like we went through a little bit about how to order the Sublocade, and we should, as a team, create a plan in advance for each prescription as things are being transitioned for different patients. For example, what day the prescription will be dispensed and picked up, who will pick up the prescription. There's other additional information that the College of Pharmacists of BC might require, and that's in process of being looked at in terms of storage requirements as well. Sublocade can be picked up by a nurse or prescriber on behalf of the patient, or it can be delivered to the clinic. Again, keeping in mind proper storage and delivery of the prescription by College of Pharmacists of BC's requirements, which is being looked at. Medication, as usual, it's a 1A drug. It has to be safely and securely secured, maintained following appropriate cold chain management. I know that 1A drugs are supposed to be kept in the safe, time lock safe right now, and that's something in discussion with CPBC in terms of how to manage the situation. Counseling requirements are still need to be met from pharmacy. And we are advised from the college to only stock the amount of Sublocade needed to avoid some of the overstocking. And I do understand there's limitations in terms of the ordering requirements and the ordering minimums from this particular wholesaler site or the ordering site. Apparently, you might need to order 2 boxes at a time, so that needs to be built into the workflow. The other thing, of course, is whether or not there's timely pickup of the medications. So buprenorphine, simply put, the same as the Suboxone mechanism of action. It's the partial agonist, as a reminder, the mu-opioid receptor. Very high affinity. There is a ceiling effect for the respiratory depression, so that's why this was one of the reasons why it could be first-line therapy in terms of buprenorphine orally when it came out compared to more methadone. Administration right now, it is in British Columbia, administered by a physician, a nurse practitioner, a registered nurse, or a registered psychiatric nurse. In other provinces, pharmacists have asked, are they looking at pharmacist injection authority? And that's in the works, perhaps, with other provinces looking at it. And again, things do change in flux, so do keep an eye out on who's able to administer. Healthcare providers, there's an agreement between Health Canada and the company that required training in administering Sublocade prior to treating patients. And it's just a very simple login procedure for Sublocade certification. And those that have completed it will receive a certificate in the email that demonstrates that you've actually look through the training requirements on the company's website with some of the certification processes. And Leela is going to go through a little bit of the nuts and bolts of some of the things that have helped in terms of some of the injections that she's done or her team has done. Please note, this is very different. I know that there's been talk about that prescriber certification needs to be shown to pharmacies before a pharmacist can actually dispense a medication. This is not a requirement in British Columbia because colleges, regulatory colleges are not, registrants of regulatory colleges are not to police or look after the training requirements of other registrants in other colleges. So in British Columbia, this certification does not need to be provided to the pharmacist or pharmacy prior to dispensing a prescription. That is in process in terms of how to, your own colleges as prescriber colleges might look at different ways of looking at whether or not a certification process was completed. So that's also in the works. So just remember, you in British Columbia, if you're a prescriber of Sublocade, you do not need to fax a copy of the certificate or show a copy of your training certificate to the pharmacist. And the manufacturer's website provides additional information on administration, but we will go through how to do this. This is, Paxton will go over a little bit more about some of the randomized double-blind study throughout the third session of our webinar series, and he'll give you a little bit of an overview in this session as well. You're really looking at a lot more gastrointestinal disorders. So basically it's placebo compared to Sublocade. It's 300, 300 for 2 months, and then 100 for the next 4 months in that column. The last column is Sublocade, 300 milligrams injected subcutaneously over 6 months of time. So there's a bit of gastrointestinal disorders and then some fatigue, a little bit more prominent in some of the patients. And then some of the ALT liver enzymes might be elevated a little bit over time. So a little bit of a bleep up in some of the individual patients. And then some headaches, sedation overall, and some hard time sleeping for some patients, depending on the situation of when people were looked at with some of this this particular study. In terms of injection site adverse reactions, I mean, we talked to corrections a little bit more, and some of the corrections experience hasn't been a lot of injection site adverse reactions compared to the studies. On the left-hand side, it's the randomized double-blind study. On the right-hand side, it's really open label study over 12 months where people were followed. In the corrections that we talked to with the 50 plus individuals that were using Sublocade over the last little while, at least almost a year now, they haven't seen a lot of injection site reactions, but Leila has seen some potentially with some of the younger group and also some of the pain associated with the group. But she'll go over some tips and tricks to how to avoid some of these reactions. Very rare serious adverse reactions that you should keep in mind. Of course, there's anaphylaxis potential because remember, we are injecting a polymer in a person in the subcutaneous part of the skin. So potentially there is a potential for anaphylaxis because it's a foreign polymer that's been injected in. As with any opioids, there's potentially adrenal insufficiency that can happen. So these are some of the signs and symptoms that you can definitely look at and keep in mind as you go through, not just for Sublocade, but also with some of your other opioids like methadone, or even if individuals are on morphine for other conditions. And then these are other things that are listed, like I said, with the Atrigel drug delivery system, please make sure, like if you have new staff in and you're, you know, going through grabbing things from the fridge or things like that, make sure people know about this injection, because the worst thing that can happen is it goes through IM or even IV by accident instead of sub-Q, because it can cause severe tissue damage. And as you know, there's a lot more fluid within an IV administration potentially, or even potentially IM, because what happens is that the Atrigel delivery system will completely form a solid mass, and there could be other events that can happen. Interactions, as with any other, like as with buprenorphine, definitely benzos, alcohol, CNS depressants. We went through a little bit of this in the other webinars, potentially because of looking at respiratory depression issues that can happen. So be really careful as you take your patient's history, you look at different things happening with your patient. For pharmacist colleagues out there, again, you know, you usually see many patients more consistently over time as they pick up other medications. So do have a conversation on how things are going, especially in this dual pandemic where there's a lot of stressors going out. Sublocade is broken down by CYP3A4, so there's the inhibitors and inducers that can cause reactions, and these are definitely drug interactions that can happen, and it can happen with either there would be a bit of a too much drug inside the system with an inhibitor, and so what ends up happening is a person might present looking a little bit more drowsy than usual. So do keep these things in mind. Serotonergic reaction in drugs, very unlikely, but there is a theoretical risk for sure, as with any other Suboxone product. Kinetics wise, the standard ADME absorption is really 24 hours, distribution really large volumes, so going throughout the body. Like I said, it gets metabolized by CYP3A4 basically to a norbuprenorphine. So therefore, you know, if you have a really an individual that has a very severe hepatic impairment, it is contraindicated in these particular individuals. Elimination, urine and feces the same as how it is metabolized. So it is eliminated in urine and feces. Half-life is quite long, time to steady state. That's why some of these studies are looking at really more of a longer term look at things, is really a 4 to 6 month period. So serum concentration. So an average buprenorphine plasma concentration, so that you know, of about 2 to 3 nanograms per mil are associated really with the mu receptor occupancy of greater than 70%, and potentially the reduction of illicit opioid use. So I'm just going to go through a little bit more for you in terms of what this table looks like. This is out of one of the studies that Paxton and others will go through in the third session. So they were looking at Subutex, which is just a buprenorphine alone, not with the naloxone. So at 12 milligrams, there was a steady state on average. So minimum concentration is 0.81, maximum concentration is 5.35, and then the average is 1.71 after one dose, and then within the steady state, roughly after a few doses there. 24 milligrams, you're looking at 1.54 at minimum of a dose, and then the maximum was 8.27, and then in the middle there, the average was 2.91. On the right-hand side, the Sublocade, so that you know what your numbers you're looking at when we go to the next slide. The first injection, so this is exactly at the first injection, and let me just remind you, it's usually 2 injections of the 300 milligrams, and then 4 injections of the steady state of the 100 milligrams. That's the next column, and then 300 milligrams is the next column, which is the 4 months on some individuals that chose to have that administered. So 300 milligrams, the first injection, the average was 2.19, and then the C minimum at that time was 1.25, and then the C max was 5.37. And then at the 100 milligrams, so this is 6 months afterwards of the initial 2-dose injection of 300 milligrams, you're looking at an average of about 3.21 of the C average concentration. And then at the 300 milligrams steady state, after about the 4 months of this, after the 2 of the 300 milligram injection, first injection, second injection, you're looking at 6.54 on average. So Tamara, Dr. Micek has actually in the next slide provided us with a visual look at everything. So this is more of a look of everything of how the Sublocade is trending down after an injection at steady state. So on the left-hand side, the y-axis, you see the plasma concentration in nanogram per mil. She's graphed this over a 28-day period, so almost a 30-day period. The red is the 300 milligrams subcutaneously of the 300 milligram injection over time, and you can see that the average plasma concentration is still above that 2 to 3. We were talking about the 70% occupancy of the receptors. So you're looking at anywhere from 10 to just a little bit below the 5 mark. And then there is a dark blue that you see line that is a 100 milligram subcutaneous injection of the Sublocade. And you can see the trend at the initial injection of around 5 going down to just about 3. So it's still above that 2 to 3 nanograms of the receptor occupancy required for the 70% of the mu receptor. And then the other ones that are jagged up and down is really the daily dosage of the 12 milligrams sublingual Subutex tablet and the 24 milligrams sublingual Subutex tablet. And you can see that it's jagged, not as smooth of a plasma concentration with the day-to-day. So that's something that Tamara has graphed for us to just have a look at the differences in the different formulations available. And I'll get Paxton to start discussing some of the randomized double-blind study here.
Sure. Thanks, Mona. Thanks for that very thorough introduction. Before I move forward, I've been sort of typing some answers to the questions that I see here that have come up, but we have a few that come up, which we can maybe take a moment to answer some of these questions right now before I carry on. So Mithra has asked whether we can leave the box out at room temperature for a full 7 days and then place it back in the fridge at that point, or would it need to be disposed of? I will. Why don't do you have any thoughts on that, Mona?
She might be muted. Mute her. Mona, are you muted?
I can say I'll wait for her to sort of her audio, but I can say that I don't really see a situation, hopefully, where this would
I'm
come up.
not muted, but yeah, you can't.
Yeah.
Anytime it's 15 minutes out, it's basically you can't put it back in the fridge. There's no guarantee, so you have to use it up within the 7 days at that time.
Hope in our situation, the way that we've set it up with our clinic, which I think is pretty standard, is we have an agreement with a specific pharmacy and we communicate pretty carefully around all of our orders with them and our planned date of administration. So it comes out of their refrigerator to us on the morning of our planned injection. We have a refrigerator in our clinic that we can keep it in until the patient actually arrives. We take it out 15 minutes or so before we actually administer it to let it warm up. So hopefully that that wouldn't come up. We have another question here around the rationale for sending a password in a separate email from the username. I'm not sure.
That is related to how the drug is ordered. I don't know why, but those are things that need to be set up accordingly. So it's their system for ordering.
The next question is whether physicians need to complete the SUBLOCADE training online, and the answer to that is yes. If you want to prescribe this medication, you need to provide a pharmacy with your certificate of completion before they can fill your prescription and order that medication. So again, a reason maybe to pick a pharmacy near your clinic that you're going to work with on this. And in our case, they keep all of our certificates in a filing cabinet there. So for easy access when we place our orders.
And that is no longer required from BC. So
is it?
No, it's no longer required. That's something both, actually all the colleges are talking about, because we can't, registrants from one college is not to be looking at whether or not a person is certified from another college. So that's being worked on. But I know for sure in our bulletin, we've also said that it is not required to send a certificate to the pharmacist before they fill it.
Sorry, just to clarify, Mona, they don't need to send the certificate, or you don't need to have actually taken the course?
We don't. No, you need to take the course, but the pharmacist does not need to see a prescriber certificate.
Okay. We have a question about whether LPNs why they are not listed as being able to administer SUBLOCADE.
Unsure. That's part of the college, the nursing college. We did double check with them, and that is a list that they gave us. It could change. Like things are changing so fast right now, so that's something that we will keep an eye out as well.
And the next question here, we're almost at the end of these, is what's the typical turnaround time from the day that the pharmacist receives the script to the day that they actually receive the item itself?
In Vancouver, they have guaranteed us that it should come within a couple of days. However, it gets shipped from out east, and there's certain days of the week this place does not ship out. When you are on the island or up north, you could look at an additional couple more days. But again, that depends on forest fires. It depends on snow and some weathers. Some disturbances in weather, especially if there's planes flying into the smaller communities.
In our case, they've told us 24 or 48 to 72 hours, except for the other limitations right now because of
they
COVID
ship
restrictions.
COVID
COVID's
restrictions,
also slowing things down potentially as well.
They ship Monday, Tuesday, and Wednesdays, no deliveries on Thursdays or Fridays. So what that means for people on the island and also up north, and in these circumstances of fires, etc., like what I said, you have to build in time and watch for holidays as well, long weekends.
Next, we have to clarify regarding the certification piece. Are healthcare providers other than the prescriber required to do the certification prior to administering the injection? And I believe the answer for that is no, although you may find it beneficial to do it just for your learning.
Yeah, that's correct. And can I add one more thing? It might be 2 p.m. Eastern cutoff time too, which provides a lot of workflow realignment from community pharmacy. So if you are bringing this in for your mutual patients, please do watch cutoff times, you watch holiday times, etc.
And in our experience, it's been really just, it'd be easy to communicate with the pharmacist. They've been quite aware as to kind of the timing involved, and I've actually been pretty impressed at how quickly we've been able to get a hold of the item itself. As far as for adverse reactions go, how do their adverse reactions with Sublocade compare to those with sublingual buprenorphine? Now, they haven't ever been compared head-to-head in any sort of trial, but certainly most of the adverse reactions that you're seeing described here are pretty common to oral buprenorphine as well. Things like headache or constipation. Or potentially the low risk of things like elevated liver enzymes. The ones that are certainly specific to Sublocade itself are the injection site reactions, including discomfort, erythema, as well as the possible risk of infection there, which are certainly specific to Sublocade itself. Another question on continuing oral Suboxone until reaching steady state. So the answer to that is no. Steady state, depending on whether you step down to 100 milligrams after 2 injections or whether you remain at 300 milligrams, steady state can take anywhere from 2 months to 6 months to achieve. But that's different from peak effect. You get peak effect with your injection of within about 24 hours of administration. So we tell people to continue to take their buprenorphine as they have been. So if they take it in the mornings, I tell somebody to take it in the morning and come in the afternoon for their injection. And if they typically take it in the afternoons or evenings, then I tell them to come get their injection and don't even bother with your evening dose. And here we have another question about as it takes months to achieve steady state for patients previously steady on 24 milligrams and feeling withdrawals after day 17 or so, would you recommend oral top-up dosing? So I will get into this a little bit more in session 3 of our webinar program here, where we talk a little bit about some of the evidence out there behind Sublocade. But the short answer to that is that yes, it's not uncommon in the beginning. It's a minority of patients, but it's not uncommon to have to supplement with some sublingual buprenorphine for some of the time. And that there's a variety of reasons why you might need to do that. But you highlight one of them here is that with the first injection, as the dose is starting to come down before your second injection, you may start to enter a subtherapeutic zone where you would need to supplement with some sublingual buprenorphine. Next question is, can we use if patients currently taking doses higher than 24 milligrams daily? So the answer to that is certainly, as you saw in that figure by Tamara, that the 300 milligrams, once you achieve steady state with 300 milligrams, your dose, your serum levels are very high. Your serum levels peaking over 10 nanograms per ml, which is probably equivalent to about 40 milligrams of Suboxone, and your trough is still equivalent at the very least to sort of the mean, or probably higher than the mean level of what you're getting on 24 milligrams. So if you remain at 300 milligram doses, your average, you're getting quite high doses. And so you should be able to still use this medication. Just a couple more here. So this is, we know that a more effective dose of Suboxone currently is greater than 16 milligrams. The 300 and then step down to 100 seems to be more equivalent to 12 milligrams sublingual. Can we take that to mean it is likely less effective? And are there patients that would be on Sublocade and oral as a top-up? So I will address this actually just with, I'll address this question with the upcoming slides when we talk about this one article here that was sort of one of the quote unquote landmark papers for Sublocade. And lastly, emailing this Lancet article and any helpful guidelines or clinical recommendations. I will leave that to Amanda to sort out what's coming.
Yeah, there's going to be a lot more information coming from us, so you can bet we'll send those to the prescriber blast, including links to these recordings if you want to refer back to it, but also send to your colleagues. Thanks, Paxton.
A couple other questions came up in the interim. I'll answer those quickly just to get them out of the way. From what I heard previously from a group using Sublocade in Ontario, they did not take Suboxone on the day of injection, but stopped the day before. Is there a preference for when to stop the SL dose? Not really. There's no. It probably doesn't make a big difference. If somebody takes a dose in the morning and they're apprehensive about not taking the dose in the morning because they feel withdrawal come on quicker, then I will tell them to take their dose in the morning before coming in for their injection. Stopping the dose the day before would be entirely reasonable as well. You reach peak serum levels quite quickly with the injection, so that's more of a you can kind of sort out an appropriate schedule with your patient based on when they usually take their dose. Is it safe in pregnancy? And is there an age limit? So the trials did not include anyone who was pregnant, and the age limit here was 18 to 65. Mona, do you want to talk any further about that?
No, and then there's, when you're applying for special authority of the individuals under 18, you certainly need to provide what the clinical reasoning is and all that, but nothing else I can say about that.
As far as pregnancy goes, I can't recall what the product monograph says about that.
Oh, pregnancy, it's fine.
Okay.
Yeah. We
know that buprenorphine itself is safe
in
pregnancy. It's just the carrier itself. Okay. Yeah. So sorry. Go ahead, Maura.
No, it's fine.
So I'm just I'll get into the next section of the. I think we've got through all the questions for now. We're happy to take more follow-ups as the presentation goes on, but I'll get into just talking very briefly about some of the evidence. This is mostly sort of a teaser more than anything for the third webinar session that we have scheduled for June 11th. I'm not going to get into too much data right now, but I thought that it would be for those who maybe aren't going to be able to make it to that third one. I thought it'd be worth presenting at least this one article, because this is sort of considered, I suppose, the landmark trial as far as Sublocade goes. So this is a Lancet paper published just over a year ago now, March of 2019, comparing the efficacy and safety of monthly buprenorphine depot against placebos. So this is a randomized, multi-center, double-blinded, placebo-controlled trial. And I'm going to point out two things about this trial that before even moving forward at all is that, first off, you are reading that correctly. They're comparing the depot buprenorphine to a placebo injection. So the placebo control group here was not receiving any OAT whatsoever. It is not compared to sublingual buprenorphine, which is, I think, a bone of contention around this paper. And the second item that I will highlight is that this paper was almost entirely conceptualized and driven by Indivior, by the makers of Sublocade. So they were quite involved in every aspect of this paper. So take that for what it's worth. I will, again, I'm just going to briefly kind of cover this. This was a multi-center randomized double-blind placebo-controlled trial. It was quite, generally well done. The inclusion criteria for this particular study were adults, as I mentioned, 18 to 65 years old. You needed to have a moderate to severe opioid use disorder as per the DSM criteria, and have had that diagnosis for at least 3 months. And they also had a BMI requirement here. Now, I've asked follow-ups as to whether there's any BMI restrictions in terms of people that you cannot use this medication with, and I was told by Indivior that it's acceptable in any BMI. But there was this inclusion criteria for this particular trial. They did have a number of exclusion criteria to their patients here. This is a pretty highly selected population they've studied. So they've excluded any pregnant or breastfeeding female, anyone who's got any other indication for opioid, anyone with any other active substance use disorders other than tobacco use or mild cannabis, cocaine or alcohol use disorder, anyone who's incarcerated, had a history of suicidal ideation, or uncontrolled medical or psychiatric illnesses. So there was even more exclusions than that. It's a very highly selected population. Let's just say that. So this trial itself, what they did, as I mentioned, this is a placebo-controlled trial. So they took their population and they did a run-in. They started them all on sublingual Suboxone. So whatever group you're randomized to, you were initially induced onto Suboxone and stabilized on the dose anywhere between 8 to 24 milligrams. That was sort of the run-in period. At that point, you were randomized to one of three groups. So on day one of this trial, you would either receive a Sublocade 300 milligram induction dose, and that would be done for one group. You get 300 milligrams on day one and on day 29, and they would drop down to 100 milligrams as a maintenance dose after that, which is, as you've seen, sort of the standard way that this is to be prescribed. There was a second arm where they started on 300 and they maintained them at 300 throughout. This trial ran for 6 months, and they maintained people on 300 milligrams every 28 days for the entire 6 months. The third arm, which was the placebo arm, was stabilized on Suboxone sublingual film, and on day one was injected with the Atrogel itself, but no active medication in that. And they were then taken off their sublingual Suboxone. So as you see here, there's a little asterisk that the sublingual Suboxone was tapered off over 5 days after the first injection to help mitigate, potentially the withdrawal that group was going to experience, being taken off their medication quite quickly. That actually was added partway through the trial, so about half of the placebo patients were just stopped on day one. The other half got a 5-day taper, which, as I think you can imagine, would be pretty. As a patient, I think it'd be fairly hard to remain blinded if you went through acute withdrawal within those first 5 days. But that maybe is my own interpretation of this. As I mentioned, the control for this study was a placebo injection, and their primary outcome, what they were looking for, was percentage abstinence from opioids. So they were looking at a combination of urine drug screens and self-report, and they defined their primary outcome was defined based on percentage abstinence. They identified a key secondary outcome, which was based on achieving 80% abstinence by the time 6 months rolled around. A number of secondary outcomes were included in this study, including craving scores, withdrawal scores, adverse events, etc. So I will point out just a couple of the results here. As I mentioned, we're going to talk more about this data on session 3. So this is a Kaplan-Meier curve that shows study retention. So I think for most of us, this is not a great surprise. So the purple line represents those that got the 300 milligram induction doses followed by 100 milligram maintenance. And the red line is 300 milligram induction with 300 milligram maintenance. And you can see that the retention for those two groups was both quite good. So right up to 6 months, they retained about 75% of their patients out to 6 months, which is pretty good retention, I think. Not surprisingly, those who were placed in the placebo and rapidly tapered off their sublingual buprenorphine had a much poorer retention rate. You can see that drops off quite quickly right off the bat, and by 6 months, less than 50% of those patients were retained. That's not a shocker to most people. I think that you lost the placebo group, but I will point out that there wasn't any difference, at least in retention, between those that remained at 300 milligrams versus those that dropped down to 100 milligrams. So this is probably the key slide then. So this is abstinence rates throughout the study. So you can see, again, purple represents those who are receiving the 300 milligram induction with 100 milligram maintenance. Red represents 300 milligram induction and the 300 milligram maintenance, and blue is the placebo. So again, within 2 weeks of randomization, you can see a pretty profound drop off in the placebo group in terms of those that remain abstinence. And really, for the rest of the trial, that number trucked along at just under 10%. Now, this is, again, I think the important thing to note here, though, is, again, one, that their abstinence rates were in the range of 50% throughout the trial, which, again, this is complete abstinence, which is obviously a pretty high bar to set. And I think those are Pretty impressive results. No difference here seen at all between the two groups, the maintenance at 300 or the maintenance at 100. So these are just a couple of examples of some of the other measures that they did here. So in the top left, we have the mean COWS score or withdrawal score throughout the trial. So you can see fairly low in both the 300 and 100 milligram groups. Sorry, I've mixed up my labels here. The top left is opioid craving. The bottom right is withdrawal. That's my mistake. So the top left is actually opioid craving. You can see that opioid craving in the two treatment groups is according to their VAS score is pretty good, whereas not surprisingly, craving in the placebo group is much higher. Again, really the important detail here is no difference between 300 and 100. And in the bottom right, that is your mean COWS score. So you can see, again, in the treatment groups, no difference between 300 and 100 and a fairly low COWS score, a COWS score of 2 or less throughout the duration of the trial. Slightly higher in the placebo group, maybe, but not actually all that high of a COWS score. And that's likely because almost everyone in the placebo group was using opioids throughout most of the trial, as per the previous slide that we saw. Next slide, Amanda. So the last thing here is just highlighting adverse events. So you can see I've highlighted here any treatment emergent adverse events. So a lot of adverse events noted in all three groups. Slightly higher numbers of events noted in the treatment groups compared to placebo. But if you look down in the subcategories, serious treatment emergent adverse events were quite low. And there was actually quite a low number of events leading to discontinuation, perhaps a little bit higher in the treatment groups compared to the placebo group, particularly the one that was maintaining patients on 300 milligrams. Only one death, and that was actually from a gunshot wound. So if you look at the paper itself, it breaks down all the various subcategories of adverse events, but Mona already kind of covered those, and I wasn't going to get into that any further. If anyone has interest, you can find those in the paper. So that is in sort of a very quick summary of, again, what sort of marketed as the hallmark paper for Sublocade. I think that the fact that they're comparing it to placebo is a huge issue. It's really hard to say what to take from that trial when they're comparing it to patients who are receiving no treatment whatsoever. But at the very least, I hope this answers the question that came up asking about 300 milligrams versus 100 milligram. For the purposes of that particular study, there was really no difference identified between the two groups as a whole, although there was some slightly more adverse events noted at those who remained on 300 milligrams throughout. Now, not to give away too much as to what we're going to get into in the June 9th session, but I'll mention for those who aren't able to make it that there's a subgroup analysis that has been done from that trial, looking specifically at those whose primary route of administration was injection drug use, and in people who primarily use IV drugs, it does seem like that is a subpopulation that may benefit from staying at 300 milligrams versus dropping down to 100 milligrams, which I think is not surprising as a whole. I think a lot of us would, when we think about sublingual doses that would maintain our patients, that's not a surprising result. That has not been published in paper form yet, but I'll be talking on the June 9th session about a poster that was presented at the American Society of Addiction Medicine last year that discussed that subgroup analysis. So the last thing I'll point out here is something called the RECOVER study. One last thing, and again, we'll dive into this a lot more on the June 9th session. Since that very, very highly controlled clinical trial, many of these patients have been continued on the medication and followed over time, and additional patients have also been enrolled and followed in sort of more of a naturalistic study, following people over time. There's 2 papers that have come out since then. This is just one of them. That kind of describe sort of the long-term effects over time in less of a controlled setting. In this particular study, which is a 12-month follow-up of patients from this study, those who received all 12 injections who remain engaged through the duration of the study, their abstinence rates at 12 months was 75%. Compare those to those who just received 2 or less injections throughout the duration of the study, and their abstinence rates at 12 months was 24%. there's a second study that's being couched in here, which is also an additional publication we'll talk about, that's looking more at patient-centered outcomes like quality of life measurements and employment rates. And employment rates of participants on Sublocade who remain on Sublocade double over 12 months. So there is some more patient-centered data out there too, suggesting that that this can be a very helpful tool for some. So that's all the data that I wanted to talk about today. I don't want to bore anyone too much, but if anyone has interest in kind of diving into this a little bit more, we'll talk about the RECOVER study, some of the sub-analyses, and some other kind of interesting work that's come up more recently in the June 9th session.
Great, thanks, Paxton. So I'm hoping in this portion of the presentation just to mention a few aspects of the Sublocade program that we currently have at Boundary Vancouver Granville, which includes some of our assessments and of course administration of the medication. And hopefully, if there's time at the end, also to go over a short case study on how Sublocades worked for one young person here at our clinic. So our care team here at Boundary for the Sublocade program includes our addiction specialist, Dr. Azar, our nurse practitioner, Karen Mitchell. We have 2 RNs with the program and a social work coordinator. Youth also have access to our peers here at the clinic, groups at the clinic, as well as primary care. We work in a partnership with a community pharmacy, which is close by. So as Mona mentioned previously, it can take a little while for orders to get to pharmacy. We usually like to give about 1 week prior to the injection date to have our prescriptions over, but we have been able to get the medication sooner, I think in 3 days. The pharmacy keeps our medication refrigerated, and it's an RN that picks it up. We were in the past using a courier or unregulated staff with a lockbox that just our clinic and pharmacy had the code for. And as already mentioned, again, once removed, we do put the date and time on packaging. It needs to be used within 7 days of removal from cold chain once it's been out for 15 minutes. So if you do have narcotic storage on site, it is possible if there's a missed appointment to just keep it on site instead of returning to pharmacy. Great, so our intake assessment here at the clinic, it's very much like a standard opiate agonist therapy intake. We want to make sure vital signs are done, blood work, there's an ECG on file, and we have a complete substance use history and medical and mental health history. And I think that we've also put a little more emphasis maybe on client goals, given that it's an injectable medication and has a longer half-life. So eligibility here, able to stabilize or stabilized on sublingual buprenorphine, informed consent, moderate to severe opiate use disorder, and we have a youth mandate of age 12 to 24. So assessment considerations at our clinic for dose 1. This is usually a different appointment than the actual intake assessment. So we've been able to move some of these first doses to our RN staff. And because it's their first dose, there are a few things we want to verify. First, that they do have buprenorphine in their system. So we usually do a urine drug screen to verify that, as well as do a Medinet check or a medication administration record if they've been inpatient, just to make sure that they've had those sublingual doses. We do a urine pregnancy test for all female patients. And we want to allow lots of time for questions and also education the first visit. So as Mona mentioned previously, an emphasis on education around safety. So to continue to try to avoid using other depressants with Sublocade, so to avoid benzodiazepines and alcohol. And we also want to just review what the injection looks like and sort of what to expect. And of course, harm reduction education and supplies and Narcan training. So for the actual administration, as it was mentioned, the Sublocade comes in a box with a single dose and a pre-filled syringe and a safety needle. And yeah, go to the next slide. So we do want to check the clarity of the liquid. It can really range in color. This is not a variation in potency. We usually see it as a honey-colored, quite viscous, kind of the consistency of honey as well. But we do want to look it over just to make sure there's no contaminants or particles in the medication. And if there is, we want to follow up with pharmacy. So we only use the needles that are provided by the manufacturer that come with the Sublocade. As it was mentioned, it's a 19 gauge 5/8" syringe or needle, sorry, and it connects with Luer-Lock system. So actually choosing an administration site, we want to find a site, the only approved subcutaneous injection site that's approved for this medication is on the abdomen. So there could be other medications that can be delivered through the subcutaneous route, but Sublocade is just through subcutaneous delivery on the abdomen. So we usually rotate by 4 sites. Usually it doesn't really matter where we start. We try to keep in a clockwise motion. So the first site, if it's upper left, then that would go in a clockwise motion and you'd return to that site on the 5th injection. We usually go about 1 to 2 inches from the umbilicus, anywhere that you can really get a good pinch of adipose tissue. And of course, we want to make sure that the skin's free of any nodules, lesions, infection, or scarring. And of course, clean the injection site well with alcohol swab. I really recommend letting the site dry completely, not just to avoid irritation, but also because you do have to hold on to that pinch through the duration of the injection. It's really difficult to do if there's any sort of moisture on the skin. So at this point, you can hold the syringe upright, and if there's a larger bubble, you can sort of pull back on the plunger and depress it and try to remove that air bubble. The small bubbles do not matter, so I wouldn't recommend spending too much time trying to remove those just because the medication is so viscous and you want to avoid spillage if you can. So once the medication is prepped and you've chosen your injection site, you want to pinch the skin around the injection area, and you want to be sure to pinch enough skin to fully accommodate the size of the needle, so the full length of the needle. You then want to lift the skin and the adipose tissue that you're pinching up from the underlying muscle as much as you can. As Mona mentioned previously, you really want to avoid an accidental intramuscular injection and definitely an accidental intravenous injection. Due to the Atrogel solution, you can cause both damage to tissue and embolus. So once you have a good pinch on that area and your patient's ready, you insert the needle fully into the abdominal subcutaneous tissue. The actual angle of the injection it sort of depends on the amount of subcutaneous tissue you can pinch. But we usually use a 45-degree angle and find that that works well with most patients. Again, you want to maintain the pinch with the other hand throughout the full injection. You don't want any sort of displacement during the procedure. And we really recommend you inject slowly over a full 60 seconds. And I'll talk about that a little bit more when we talk about troubleshooting around pain. So once all the medication's been injected and the plunger's been fully depressed, you want to withdraw the needle at the same angle you've used for insertion, and only then after the needle's removed, then you can release the pinch skin. If there is any bleeding or medication leakage, it's not very, you can sort of dab with gauze a little bit or put on a bandage, but rubbing the site or actually putting any pressure on the area is not recommended. So yeah, after the shot's done, there is some patient education we want to do. We usually let the client sort of rest in the supine position, which I'm sorry I forgot to mention earlier. This is a procedure that we do use our exam room for so that they can be lying fully supine. We want to advise them that there will be a lump for several weeks, and we'll talk about this a little bit more too when we talk about troubleshooting around body image. It's usually not something that you can actually visualize, at least not on most body types, but you can palpate it. It sort of feels like a dime-sized nodule underneath the subcutaneous tissue, and it stays there for a few weeks. Sometimes even when the patient returns after 4 weeks, you can still feel a little bit of something under the skin, just slightly. So our post-dose education and planning that we do here at Foundry, so we do ask the patient to stay for 15 minutes after the first injection, and this is in case of anaphylaxis. We want them to keep waistbands and belts off the injection site. Any sort of pressure over the area could agitate the site. And some discomfort the first 48 hours is expected. Sort of like a flu shot, it is an injection, so there is going to be a little bit of soreness at the site, but we also want to let them know that, you know, longer than 48 hours, or if they're seeing an increase in redness or edema, that they do want to come back to the clinic. And again, just that the bump under the skin is totally normal and expected. Also here at Foundry, we make sure that we've confirmed all contact info, and we do have our RN call within the next 24 to 48 hours. As Paxton was mentioning, some withdrawal with the first dose. I find that it's sort of been common here, and it looks like from the studies and his experience as well, that there could be withdrawal just, because of the differentiate in doses. So we book a follow-up appointment with a prescriber in 1 week for the first assessment after they've received their first dose. And really from there, if the patient's stable, these can be ongoing nursing visits with, of course, the option of escalation to the prescriber if there's any concerns. So our assessment considerations for every 4 weeks. This is when the patient would come back if no other concerns for their regularly and scheduled injection. We continue pregnancy tests if there's no reliable birth control. We want to review the documentation to make sure we're reviewing the last site of injection and that we're rotating sites. And of course, we want to assess any ongoing cravings and withdrawal and the benefits. So has this person been able to meet any other goals? How is the Sublocade actually working for them? And their substance use goals. Have they found that there's been an increase in use, maybe an increase in use in other substances, a decrease? So we really want to assess how the Sublocade is actually working for the individual. And of course, we continue with harm reduction education and supplies and providing Narcan. So transitioning back to sublingual buprenorphine, Paxton, I'm not sure if you want to cover this slide if you've had some experience at RAC with this.
I have not had any, we have not had any direct experience transitioning back to sublingual, although I have had some conversations with some US doctors around this who have, and they've basically highlighted the exact, I mean, you're welcome, these two options as both kind of reasonable ways to approach both a transition back to sublingual, or if you wanted to, if somebody wanted to taper off buprenorphine entirely, that these are both kind of reasonable approaches to take. So the first would be reinstating somebody on their sublingual dose on the day following, the day when the next injection was due. So 28 days from the previous injection, just restarting them on a sublingual dose that would be more or less the last dose. You might want to dose reduce slightly because they're still going to have some buprenorphine in their system, depending on how many sub-Q doses they've had. But I think it's just going to take a little bit of tinkering to find out what their new dose is, and that may change as well over time if, as again, the subcutaneous depot kind of runs its course, which does take longer than 28 days. So that would be one approach. The second would be to do exactly what you've highlighted here, which is just wait until a patient's cravings return. The rate at which the serum levels drop off for Sublocade should be sufficiently slow to not put somebody into significant withdrawal symptoms. It's quite a slow taper over time. So
Great, thank you. And again, just a reminder of the transition and dosing schedule. So prior to receiving Sublocade, patients must be inducted and stabilized on a sublingual buprenorphine naloxone 8 milligrams to 24 milligrams a day dose for a minimum of 7 days. Patients are always started at a dose of 300 milligrams Sublocade for 2 months, followed by a maintenance dose of 100 milligrams per month. Of course, with the discretion of treating prescriber, the maintenance dose may be increased to 300 milligrams a month if the patient experiences ongoing opioid cravings, illicit opioid use. And Sublocade doses are administered at a minimum of every 26 days. So missed doses, the dose can be, the next dose can be given as soon as possible. And as per the product monograph, occasional delays of up to 2 weeks are not expected to have a significant impact on the effect of treatment. So some common concerns that we've seen so far in our Sublocade program for both our active patients and young people that have been referred to our program and chose not to start. Keep in mind this is with a youth population. So pain of injection is a concern. Also body image. So as I was saying, really most body types you can't actually see the Sublocade, like the bump on the abdomen. But you can palpate it, and this is a concern for younger people, especially some of our younger women in the clinic. Also, just the readiness for change. So there is there's less autonomy to skip days as there would be with sublingual buprenorphine or other daily opiate agonist treatment medications. So with the ongoing effects of Sublocade, there has been some concern whether or not there's an increase in other substances if the person isn't really, if maybe they're not the best candidate for Sublocade. And also tied to that as well, sorry, just back at the last slide, just for some of our younger people that have been referred to the program too, just the possibility of perhaps a decrease in ability to feel the same euphoria related to their opioid use that they currently had. Again, in a complex population, people use opioids for a multitude of reasons. So really working with people on their goals, I think, is really an important assessment consideration when starting people. So what we have tried for pain management here at Foundry is ice times 5 minutes. So really freezing and trying to numb the area. We usually have the young person take both acetaminophen and ibuprofen about 40 minutes before their shot, which can be dispensed for them to take home and do before they come to the clinic for their appointment. We've tried topicals, so both Emla patch and xylocaine, so different types of lidocaine with a Tegaderm bandage over top. This is also something that people can do at home if they're given the supplies. What we have noticed though with most of our clients when they come in, they've either lost the supplies or this hasn't been done. So sometimes we have to do it here at the clinic and it makes for a slightly longer appointment. And also treatment of anxiety. So, you know, we've tried like a 1 milligram dose of lorazepam with some of our folks here at the clinic, and that seemed to help as well. I would say beyond these interventions that I mentioned, the feedback from young people receiving Sublocade here is that a slower injection and a room temperature medication decreases the pain significantly. So for a 300 milligram dose, which is 1.5 mils, given over a full 60 seconds, the consistent feedback that we've had is that when the medication is delivered or injected too quickly, probably because it displaces the tissue too quickly, it is more painful. So 60 seconds, like over a good full minute, which kind of works in the clinician's favor as well, because it is such a viscous medication. It's actually somewhat difficult to even try to administer at a quicker rate. And of course, yeah, leaving the medication out of the fridge for at least 15 minutes, but if it can be left out for an hour, that seems to help.
If I can jump in there too, Leila, before we move on. I think this is a place where we're all going to learn from each other, because Sublocade is a new medication to the province, so no one has a ton of experience with it. Because I've talked to a lot of people about their approaches. Our experience at the Rapid Access Clinic at St. Paul's, and I don't know if this is just if it's a patient population thing, is being a little bit different. We've also tried the EMLA. Personally, I found it to be more hassle than it's worth, because I don't think the needle is a 19 gauge needle. It's not that big, and so I don't think that needle itself is causing the discomfort as much as the actual injection is, as you've highlighted. The approach that we've settled on, and I would be happy to change my mind if there were better options, but we found with the ice pack, and not a cold pack, but an actual ice pack for a good 5, if not 10 minutes, and then actually doing quite a rapid injection followed by putting the ice pack right back on top of the place has been the strategy that we've found the most success with. So I think we're going to see different approaches out there, and whatever people find that works for them, I would encourage them to share it with us, because again, we'll all sort of learn from each other on this. I've also heard of people using lidocaine and actually infiltrating with lidocaine, which has been found to be helpful in their experience, although that would obviously would require a physician to administer, which could complicate things for some clinics. So I think we will see different approaches there. What I can tell you from the data is that the first injection is always by actual. There's actually published studies on this where the first injection is consistently the most painful, and people find less and less discomfort as time goes on. I think that's probably a little bit more related to expectations rather than some biochemical property of the substance itself. But people do report the every subsequent injection becoming somewhat less painful than the one before it. I think that answers a couple of the questions that just popped up.
Yeah, it is interesting that you mentioned that, because I can definitely say from experience here that one of our patients that's been on Sublocade the longest, he actually usually just declines any sort of topical, and sometimes even like the Tylenol and ibuprofen, and just like is fine with just ice for a good 5 minutes. And I do think, yeah, just the different populations and also people's different experiences of pain as well. Great. So I'm going to just go through a short case study just to illustrate how we've started a young person here at Foundry on Sublocade and how it's going for her now. So Jill is 18 years old. She's connected to youth services, including child and youth psychiatry, a therapist in community, as well as youth outreach workers and a primary care provider. And she's also under MCFD care. So she has a complex medical history of PTSD, ADHD, a history of self-harm and suicide attempts, past hospitalization related to mental health, and when she was referred to us was on fluoxetine, quetiapine, and Suboxone sublingual at 22 milligrams. She reports that her substance use at the time of intake, that there was no current alcohol or benzodiazepine use. She started cannabis at age 12, stimulants at age 15, opioids at age 16, and was using about 0.5 to 3 points daily of fentanyl and crystal meth both intravenously. She was experiencing daily withdrawal from opioids, had a history of psychosis related to crystal meth use, and had a opioid overdose December 2019. So Jill's treatment history, she previously had tried methadone. She was on less than 60 milligrams and did find this sedating. She had been to youth detox. And as I mentioned, she was on 22 milligrams of Suboxone. She did stop around the time that she was referred to our program and then restarted for a total of 18 milligrams for 7 days prior to Sublocade start. She reported that she didn't like the sublingual route. She found it hard to take daily and dissolve. She also reported that she thought maybe she had some withdrawal in between not taking doses and an episode of vomiting. She was referred by her primary care provider at age 17 for Foundry for Sublocade. So Jill's goals were abstinence from fentanyl. She wanted to reduce her chance of overdose, decrease her withdrawal, and as I mentioned, she found the sublingual Suboxone hard to tolerate, both routine and route. Jill has many strengths. She's an incredibly thoughtful, genuine, resilient, and bright young person, and she connects to care providers really well. So she received her first dose, 300 milligrams Sublocade in January this year. The first couple of weeks, she reported some mild withdrawal type symptoms, which she experienced as hot and cold flashes. She was prescribed a top-up sublingual Suboxone dose of 2 milligrams as needed, and clonidine 0.1 milligram. At her next assessment with the prescriber, she reports that she only took the clonidine and the withdrawal symptoms resolved in 2 days. And she did have ongoing cravings the first month. She reported that she found increased recreation and deep breathing helpful, and she did still use ongoing opioid use about 2 to 3 times weekly for a total of 1 point weekly, which is still a significant decrease from her previous use. Our prescribers decided to continue her at 300 milligrams Sublocade. So Jill now, she's just received her 6th dose of Sublocade at 300 milligrams this May. She's had no opiate overdoses since December. Her last 3 urine drug screens have had no fentanyl or other opiates, and she reports no illicit opioid use since March. She decreased to 2 to 3 times weekly, as I mentioned, and then she stopped, and she reports this was because it had no effect. She has monthly clinic visits here with us. She denies any current opioid cravings and or withdrawal, and she also started a 5-day-a-week education and work skills program, which unfortunately is currently on hold due to the pandemic. So some ongoing needs and interventions. So some ongoing crystal meth use. She had stopped initially around the time that she first stopped her opioid use, but still kind of had some crystal meth use here and there. It has increased recently, and she really relates that to boredom and isolation with COVID-19. She was assessed to have increased use by one of our RNs when she came in for her monthly injection, and then referred to our nurse practitioner prescriber who started pandemic withdrawal medications for stimulants. The team's also trying to connect her with virtual counseling and virtual groups at Foundry. She had been reporting anxiety before injection as well. So for her, we use Tylenol, ibuprofen, ice, topical lidocaine, and also 1 milligram of lorazepam pre-procedure. And she's tolerating this really well now.
All right, and before we move into our final slide here, Mona, I think you had a comment following up on the pregnancies. Oh, you might be muted, Mona.
Yeah, I got muted. Yeah, the Atrigel actually has a solvent that you have to be careful of, but buprenorphine alone, of course, that's fine to use in pregnancy. And then again, looking at risk versus benefit, but there's not that much data on the actual Sublocade Atrigel formulation. It's just a solvent that might be at risk to the fetus.
Thanks for clarifying. So I think we're a little over time, so my apologies. I think we did address those additional questions throughout the end of that presentation, but of course we'll take a look through and follow up if there's any that we did miss. Here's a list of helpful resources for you. The number one being the bulletin that we referred to several times in this webinar, so feel free to check that, and we'll be updating it as more information becomes available to us on this medication. And of course, all the training and certification pathways, ordering, how it works, the monograph, everything is there for you to take a look at, as well as the administration video that we took screenshots of the administration pathways, but there's a video there for you if you'd like to have a look. With that, I want to send a huge thank you to all three of our panelists today, but as well as the people behind the scenes helping to make this happen. So a huge thank you to the education team at the BCCSU, as well as all the folks at Foundry that helped put the slides together as well. So with that, we really hope that you'll join us for the upcoming webinars. This was part 1 of 3, as we've mentioned several times, but we really hope you'll join us for part 2, where we're going to get into some more cases, and then part 3, we're going to dive into the research. With that, a big thank you. We're going to sign off now. Hope you have a great evening, and see you soon. Bye, everyone.